Well, thank you, Fiona, for a very nice introduction. It's good to be back in Oxford and good to be back at Evidence Live. Richard Peter was talking about drugs. I will be talking about medical tests. Why? Well, this picture. I work in Amsterdam, I live in Rotterdam, and both cities have pictures at museums from Jan Steen, a 17th century painter. And here he paints a doctor's visit, and you can see diagnosis in the 17th century. The doctor is feeling the pulse of the swooning lady in obvious distress. He's asking questions to the maid about her condition, and the maid is holding a pot of urine, actually, which was one of the main diagnostics for this doctor. And that's all about diagnostics in the 17th century. Now, if I look at my hospital, and probably yours as well, and elsewhere in the healthcare system in the 21st century, there's far more than pots of urine. We have imaging, we have lab tests, we have genetics, we have questionnaires, we have function tests. In every corner, on every floor, we find these medical tests. And if we believe in evidence-based medicine, we should look for the evidence to show that these tests are worth doing, that they should be included in guidelines, and that they should be reimbursed by the healthcare system. So how do we do that? Well, the title I was given is Evidence-based or Diagnostics in Evidence-based Medicine. Where are we now and where should we be going? And I'll try to answer these questions in the little time that I have, but I'll start by where were we actually initially in the early days of evidence-based medicine. And this talk actually will address a couple of topics. I will discuss judo, I will discuss the Beatles, and I will discuss the Ice Bucket Challenge. Okay, let's start with the first question, where were we? Actually, I go back to the early textbooks on evidence-based medicine and their predecessors, the textbooks on clinical epidemiology. And if you have ever taken a course in evidence-based medicine, you probably learned about diagnostic accuracy. And that means that we compare medical tests, imaging, lab tests against the gold standards. Well, in many cases, for many diseases, we don't have a gold standard, so we rely on the clinical reference standard, the best available method that we have for finding out whether patients really have the target disease, the disease that we're looking for. And we estimate diagnostic accuracy in a diagnostic accuracy study in which we take a series of patients suspected of the target disease. We all submit them to the medical tests, then submit them to the reference standard and cross-classify the results. And here's an example from a study of D-dimer in patients with suspected pulmonary embolism seen at an American emergency department. These were over 2,000 emergency department patients. They all had a D-dimer, they all had a CT, and the results were cross-classified in a 2x2 table. And this is the 2x2 table, from which, if you've ever taken a course in ClinEpi or evidence-based medicine, you know how to learn a couple of statistics, you know how to calculate sensitivity and specificity, you know how to calculate positive and predictive values, well, maybe even can calculate the likelihood ratios or the diagnostic odds ratios. So juggling with numbers was actually around with diagnostic accuracy studies. Now, where does judo come in? Well, those who read the clinical epidemiology textbook from the colleagues in McMaster may remember that mastering the 2x2 table was compared to judo. Actually, and that means that you had to master Bayes' theorem in order to calculate pretest probabilities, post-test probabilities from pretest probabilities using likelihood ratios or sensitivity and specificity. And I made medical students and students in our courses of EBM struggle with this Bayes' theorem and struggle with the calculations. And if you became more successful, you could go from the yellow band to the orange band and the green band and the red band, the blue band, the brown belt, and eventually the black belt. That meant that you were really mastering diagnostic accuracy studies. So increasing complexity was compared to judo. And Dave Sackett and his colleagues compared this to self-defense against the wide array of medical tests that was being suggested to us. But when I think about the 2x2 tables, I think of the students struggling with the calculations and struggling with Bayes' theorem. So that's where we were initially with evidence-based medicine medical testing, judo with 2x2 tables. Now, where are we now? Well, that's the second part of my story, moving away from 2x2 tables and going to the Beatles. Now, why do the Beatles appear in this story? Well, the link between the Beatles and this story goes to EMI, and this thing, which is one of the prototypes of the first CT scanners. And the story goes as follows. EMI, Electric and Musical Industries, was a company that signed the Beatles in the 1960s. But EMI was also the company for which Sir Godfrey Hounsfield was working, and he was the engineer that originally worked on radar and was thinking of applications of inverted radar, and then invented CT imaging. And the story goes that the Beatles' greatest gift to mankind is the money they generated for EMI, which was then used for the development of CT. Now, there have been publications that this is an urban myth, unfortunately, an urban legend, but I like it so much that I couldn't resist the temptation of telling it here. So CT is the Beatles' gift to mankind. Now, why do I insert the Beatles and EMI in this story in the 1970s? Well, the first CT scan was made in 1971 in October. And it was only a head CT scan. Only in 75, actually, full-body CT scans were being developed. By the way, EMI did not pay for most of the money. That was the British taxpayers were paying for the development of CT. So thanks to British taxpayers for providing us with CT images. EMI originally thought that they would be able to sell about 4 CT machines a year. But that turned out to be a big mistake. In the mid-70s, companies in the Western world were soon buying CT machines, and that also applied to the United States. For example, in 1975, actually, there were close to 1,000 CT scans actually operating in the US only. But that put radiologists with a problem. So, because CT machines were very expensive initially, they still aren't cheap these days, but they were very expensive initially. So the radiologists were at the same time very enthusiastic about CT imaging, because these pictures were wonderful, but they were also a bit concerned. They were concerned that society would not be willing to pay for these wonderful machines. And that's why the radiologists actually devoted a whole issue of the American Journal of Radiology in the 1970s to the evaluation of computed tomography about CT. And I want to quote one element of that editorial, in that session, that says that diagnosis is not an end in itself. Physicians perform tests on patients to gain information about the presence or absence of disease, and the effect we value in its own right is the health of patients. Both the length and quality of their lives, including peace of mind. The ultimate value of the diagnostic test is that difference in health outcome resulting from the test. In what ways, to what extent, with what frequency, in which patients is health outcome improved because of this test. So this was written in 1978, and it has, before evidence-based medicine, but it seems that has gained this statement, this principle has gained momentum over the years. And I think this is where we are now. The radiologists struggled with these evaluation studies, how to document the benefits of CT imaging on patient outcome. But eventually it was clear that the ultimate proof of the clinical effectiveness, of the effect on patient outcome, would come from documenting the outcome, the health outcomes from testing in groups of patients, and comparing that to a control strategy, to an alternative form of testing or no testing at all, and looking at the very same outcomes in these patients. Now, we don't do that in the general, but we do it in a well-specified population. And if we design a study, we take a sample from that population with the study group. And in order to avoid bias, we can randomize patients to CT imaging versus control strategy, an alternative form of testing. And here we have the principle of a randomized clinical trial. So that means, and I said it 2 years ago as well, we can look at testing as an intervention and evaluate imaging or another form of testing just like any other intervention in randomized clinical trials. And we could call them the medical testing RCTs. Now, what's the problem with trials of medical testing? Well, one of the problems with trials of medical testing is that there are usually no direct effect from testing itself, from the procedure, on health outcome. Well, some tests have side effects and are harmful, but very few have direct positive effects. The only exception probably is that some people feel better if they are being examined thoroughly by a gray-haired doctor with a very low and reassuring voice. But I think I would call that placebo effects of medical testing, and I leave that to the psychologists. In our world, by and large, the effects from medical testing come from the results that these tests generate, and these results are used to guide a clinical response, for example, to intervene or to not intervene. And the difference between intervening and not intervening in the right set of people will generate the desired effect on patient outcome. So the effects of medical testing on outcome are indirect. Actually, they are the result of a strategy that relies on the testing and the downstream management consequences, the downstream actions from testing. And that's different from magnesium, from statins, and all the examples that Richard Peter showed in the first lecture, these indirect results. There are also effects on the patient side from medical testing, which we shouldn't ignore, and I'll come back to that later. So testing also has effects on the emotions, the social lives, the cognition, and the behavior of patients, and these also will affect patient outcome. So the relations are more complex. Now, if you look at the available evidence, we find very few randomized trials of medical testing. And in some cases, these trials were even invalid and not very efficient. So the challenge is, where do we get the evidence from medical testing? But in itself, the principle that we should value the health outcomes is put first and foremost by most societies, most organizations in the Western world nowadays. So nowadays we have moved, I think, from an essentialist view of medical testing to a consequentialist view of medical testing. Initially, medical tests were valued by the trueness of the results. If the results from the medical test are true, then the test must be valuable. But I see societies in the Netherlands, in the UK and elsewhere, moving to a consequentialist view of medical testing. That means that the value of a marker or a medical test is judged by the value of the consequences of medical testing, the effects on outcome. And that was applied to CT imaging in the 1970s, but it applies to most guidelines and most views on evidence-based medical testing nowadays. So not so much accuracy in itself, clinical or analytical accuracy, but the value on health outcomes. Now, where should we be going? Well, talking about judo, we have a problem with Bayes' theorem. And the problem is that sensitivity and specificity are not fixed properties. I'm going back to the example of D-dimer for evaluating suspected pulmonary embolism. This is an evaluation of two other D-dimer sets, and these are the ROC curves of these two tests. And the dots represent the cutoff recommended by the manufacturer. But this was in outpatients. If we use the very same set in inpatients, we get the following ROC curve. So not exactly the same, is it? Specificity is much lower in the inpatients than it is in the outpatients. So sensitivity and specificity are not constant. They not only depend on whether we look at inpatients and outpatients, but they also depend on the previous forms of testing. In some countries or in many organizations, we rely on Wells' rule to evaluate the clinical likelihood of pulmonary embolism. And Wells' rule looks at signs and symptoms and the history of the patients, and the higher the number of items that are positive, the higher the likelihood. Well, if we stratify the D-dimer results according to whether people score 1, 2 or more items on the Wells' rule, we get the following picture. Again, very different accuracies, very different specificities, depending on the previous test results. So sensitivity and specificity are not fixed, and I think we should de-emphasize Bayes' theorem. Well, we should not de-emphasize the theorem as such, because it's basic probability theory, and everybody in secondary school should learn about probability theory. But Bayes' theorem should no longer be central in teaching testing evidence-based medicine. We should instead emphasize the variability in measurements and the sources of it, and look for the consequences of testing. Now, what about CT scanning and these consequences of testing? Where should we go from here? Well, I thought that the basic design is not different from other interventions. The basic design is the medical testing RCT. But there are very few medical tests, and very few trials, and there will never be enough trials to come up to provide us with the evidence for all different strategies, testing strategies that we can think of. So we should, in the next years, talk more about these RCTs of medical testing. When are they really necessary? When are they justified? And when are RCTs redundant? When can we do without these RCTs? And can we rely instead on linked evidence? Linked evidence means that we take bits and pieces of evidence, for example, about diagnostic accuracy and the effectiveness of downstream actions, and put the two together without doing the full RCT. I think our group and other groups in the world will try to answer these questions about when RCTs are justified and when they are not justified or inefficient or sometimes invalid. So the place of RCTs in medical testing is something to look forward to. Now I've come to the final anecdote, and that's the ice bucket challenge. Well, why does the ice bucket challenge appear in my talk? Well, it actually has to do with whole genome sequencing. People said that whole genome sequencing or whole exome sequencing will totally change the field of diagnostic test evaluation. As you probably have seen this figure before, the cost per genome are coming down, and in my hospital people are already advocating to do a whole genome sequencing for every patient that enters the hospital. And some are less optimistic and say, no, maybe just cancer patients. Anyway, actually, these arguments can be heard. We should do whole exome sequencing and whole genome sequencing. Now, the interesting thing is that I do not hear these echoes of the 1970s and the radiologists. People do not say that we should first have the evidence that there's a benefit on health outcomes. So what do we do as the evidence-based medicine community with these upcoming trends of whole genome and whole exome sequencing? Well, to give you an example, let's go back to the ice bucket challenge. And the ice bucket challenge, as you probably remember, was a campaign to raise money for amyotrophic lateral sclerosis, a disease which is quite fatal and for which there is no effective treatment. I will introduce you to my friend Anna, and Anna's husband died a long time ago, actually, of ALS at the age of 40. And Anna has a son, and the son is about 25. And Anna came to me and asked me, well, should I do genetic testing, or should I recommend genetic testing to my son? He's healthy, he has a family already. Should I recommend genetic testing for factors that are associated with the development of ALS in later life? Now, what should we answer to Anna? What should her answer be? And on what evidence should that answer be based? Should my son undergo testing for amyotrophic lateral sclerosis? Well, let's think that there are a few genes with an association with amyotrophic lateral sclerosis. If that relation is infinity, so if there is a certainty that the son will develop ALS in later life, but we don't know whether the son has that these genetic components associated with ALS, would you then recommend genetic testing? And would that change if the relation is not certainty, but for example, higher relative risk of 100 or 10 or twofold increased risk of developing amyotrophic lateral sclerosis? Or should we just discard the evidence and let's say, well, Anna, that's completely your responsibility? Well, as taxpayers, we probably will be invited to pay for the genetic testing one way or another. So I find this quite challenging myself, because there's no effective treatment for ALS. There will be no effects on family planning for the son of Anna. He already has a family. So what then should we recommend? Should we recommend genetic testing or not? Now that problem I started with ALS, but it will be extended to all other conditions. So on what evidence should we recommend whole genome sequencing and whole exome sequencing? Should we look at it as a complex intervention, as a strategy? Well, then the intervention will change over time, because we will learn more about associations as evidence accumulates. Not evidence about the effects on health outcomes, but evidence about the associations. I find this quite challenging, and I don't have a ready answer. It will probably take another 20 minutes or so to present all this information. I don't think it will revolutionize our way of looking at things. I'm still firmly committed consequentialist myself, and I'd like to remain it that way, but how to look at the consequences of genetic testing. Is there a value of information in itself? even if that information does not include the actions? And how then do we value the consequences of just providing information without downstream management consequences? So that's a challenge that we face, I think, with evidence-based medical testing in the years forward. So when are we going to require RCTs, and when can we take other evidence as sufficient evidence for making recommendations? And how do we handle the challenges from the whole genome sequencing and whole exome sequencing? I'd like to end my story or my presentation with a brief encore about evidence in package inserts. We've looked at package inserts for medicines, but there are also package inserts for medical tests. And here is an example from Group A testing for bacterial pharyngitis. And the example was provided to me by Jeremy Cohen, a postdoc working in our group, but he's based in Paris. Now, Jeremy is interested in strep A testing, and he's interested because he knows that we and others can buy these tests on the internet, and in some countries they're provided by the National Health Service themselves. And here's an example of such a test. So it's a rapid test to test for streptococcal A antigens. Now these tests also come with package inserts. And here's an example of such a package inserts from these rapid tests. Now I'll focus on one section, and that's the evidence about the performance. And it has a brief section in there in which it says that the investigators took almost 500 throat swabs, of which 124 were found to be positive by culture. Well, here's the 2x2 table. It's provided in the package insert, and it has all the accuracy statistics, sensitivity, specificity, total accuracy, and predictive values, and so on. Now keep in mind these numbers, 120 true positives and 4 false negatives, excuse me. Now, there's not just one rapid test, actually there are dozens out there. And this is another one from a leader, and this is yet another one, another with a package insert. I'm going to the package insert, and it also has a performance characteristics. Very different test, very different company. But hey, here we have again the 120 true positives and the 4 false negatives, and the same 500 throat swabs. Well, let's look at one more rapid test. This is the Fisher Healthcare SureView Strep A test kit. It also has a package insert with instructions, and also sections with performance characteristics, with 120 true positives and the 4 false negatives. And here are 3 more package inserts. And if you look closely, you'll see again the 120 true positives and the 4 false negatives in all 3 package inserts. Now, why is that evidence in there? It seems to come from the very same study. Now, we've looked very hard. We cannot find a peer-reviewed article that documents these 500 patients. Actually, they cannot be found. More interestingly, actually, if we do a meta-analysis of all the studies that have been performed, we find the performance of these rapid tests that's not as optimistic and not as brilliant as these very high sensitivity and specificity. So that's one other challenge for our community. So can we attack these package inserts and see that they have more meaningful information? I'd like to end my presentation with this picture, if Fiona allows me. It will only take a minute. From Jan Steen, the 17th century painter. I've used it many times, and I apologize for the people that have seen me present before, because I'm very fond of this picture. When I was using this for about a year, I found out that Jan Steen has also painted another picture of a 17th century physician that's called to see a swooning lady. And here's another one, also by Jan Steen, physician holding the pulse of a lady. Here's another one, he's writing a prescription, also painted by Jan Steen. And another one, the maid again, lady in distress. And there's another one from Jan Steen, holding the pulse of the lady. And here's another one, here's the pot of urine, the pot of pee again, and the maid. And here's another one from Jan Steen, a physician's visit in the 17th century. And this won't take an hour. And there's another one, also from Jan Steen, Amsterdam, 17th century, swooning lady, a maid. And here's another one, Those who have seen me present before realize that I've extended my collection over the years. And this is a new one that I found just a month ago, also from Jan Steen, with a physician. And this is also the physician visit from Jan Steen, 17th century. This also, and we're back to the first one. Now, why does a 17th century painter produce so many pictures of a physician visit with diagnostics in it? Well, maybe you think about artistic reasons because they are wonderful to look at. But as a Belgian living in the Netherlands, I can turn this into a small joke about the Dutch. Because the Dutch always look at the Belgians, and they behave like the big brother who knows what's best for us. Well, why would a Dutchman do anything like this? Because he could sell them. He could make a living out of them. So there are people that make a living out of trade. Actually, they're traders. But that only postpones the question, why would a 17th century painter make so many pictures? Why would people want to buy them? Well, maybe because they're nice to look at, or well, they are nice to look at. The main reason why these pictures were so popular in the 17th century is that it is very obvious that this lady is suffering from love sickness, minnepijn in Dutch. There's somebody writing a letter in the back, there's a cupid, there are musical instruments, so it's abundantly clear that the lady is suffering from love sickness. The only person in the room who fails to make a diagnosis, despite his diagnostics, is a physician. Now, I hope that we as an evidence-based medicine community will do a better job in evaluating diagnostics so that our pictures will not end up on the wall or on the computer screen of future generations. Thank you very much for your attention.